So hello everyone and welcome to today's Cube Primary Care event. My name's Ramya Matthew and I'm the convener for this group. We're really fortunate to have Ursula Montgomery with us today. I'm sure many of you have met Ursula in the sort of past months, but if you haven't, Ursula is a GP and she's also Senior Clinical Advisor at NHS England within the Primary Care Division. She's had a really interesting and varied career, and she's joining us today and is going to be with us for the next hour, sharing some of her career highlights. So I am going to launch straight in because I know how quickly an hour goes by, Ursula. And I want to just firstly say thank you to you for giving up your time and for joining us. It's really kind of you. And I'm really excited to find out more about what you've done over the course of your career. So can I start just by asking you how you are at the moment and how you're doing, both as a GP and also as a leader within primary care?
Yeah, well, hi, and thank you so much for having me. It's lovely to be here. And as a GP, I was in surgery yesterday. I was very busy. I was duty doctor in the morning and dealing with a whole heap of issues, and especially for this audience, and as we're thinking about things, lots of opportunities to redesign pathways yesterday and to think differently about the work coming in. So my brain was kind of pinging with a few kind of thoughts about that. And then as a leader, I feel incredibly privileged to be in the job that I'm in. As you said, I've sort of done different things over my career. But last year, prompted by a move during the pandemic, who moves house or location in a pandemic? But we moved as a family to the east of England, and having left Leicestershire, where I was for 30 years, which is just such an enormous amount of time, I am now based in the east of England, and the opportunity to join Nikki Kanani's team at NHS England, and improvement came up. And so I would say it's been a hugely privileged year actually to work there in that role and to gain some insights into how health policy is developed and thinking about primary care. And especially at the moment, things are very, very challenging for primary care. And I suppose just to acknowledge just the way people might be feeling at the moment really, and just how much we do notice that and absorb that. Also thinking of the challenge as a leader, how to help lead a way forward through that.
Yeah, great. Thanks, Ursula. Thanks for acknowledging how much our resilience is being tested at the moment. Can I ask you also personally how you're maintaining your resilience through this period?
Yeah, so I mean, there's lots and lots of different things. So I suppose over the years, I've learned in different ways how to maintain. So I've got a family that keep me busy and kind of distracted. So when I get home, I can kind of chat to them and kind of do that. I've moved to the countryside and I enjoy going out for walks every day. And there's nothing like going for a lovely walk for a good hour or more to just decompress. And I've taken up gardening, and I really enjoy doing that. And I rely on friendships and support from other people that I've built up relationships over the years. So even in the last week, caught up with a couple of people that I've known for many years and know me, and it's good to be able to have that space to chat. And then I also have a Christian faith, and that really supports me as well.
Great, thanks, Ursula. I wanted to just, because I purposely didn't sort of cover your biography in the introduction, but you have held various roles and you've worked at local, regional and national level. And I think that there are lots of GPs that hold portfolio careers, but probably not many that have put themselves forward for the kind of roles that you have done. So I'm interested to know what spurred you on to take on those roles and also any particular career highlights for you.
Yeah, so maybe I'll just sort of weave you through the last 20 odd years really, because I think really going to medical school was a bit of a kind of an achievement for me, in the sense of I was thinking about this today. My chemistry teacher for GCSE told my mum at parents' evening, she'll be lucky if she gets a C, and I'm putting her in some remedial classes. And I went to these remedial classes at lunchtime and I ended up getting an A. And I remember saying before the results came out to my mum, if I get an A in chemistry, I'm going to apply to be a doctor. I'm going to do A levels to be a doctor. And my mum was like, what? Your teacher says you're going to get a C if you're lucky. So I got an A. So then did my A levels, and my sixth form tutor. It wasn't really the done thing in my comprehensive to go to med school. It wasn't really known about. So yeah, she thought I wouldn't get in either. So there's just been this continual kind of pushing through barriers to kind of get there. But yeah, once I came out of med school, I was going to be a physician. So I initially did my MRCP and membership of the Royal College of Physicians, and I was on the renal training path. And I had my two boys. And during my second sort of delivery of my second child, I had quite a sort of very difficult experience, and was actually quite glad he was born alive and well. And that took me through a sort of period of time of kind of realizing, what do I want to do with my career, and what do I want to actually spend time doing. And in fact, I actually went off and set up a small washable nappy company, and I was selling washable nappies. I got distributors, and I was I got a deal with the local council, and I did a small business course, and I was kind of like, I really like this. And my husband actually encouraged me and said, you're a doctor, what are you doing? Are you going to go off and do something else now? And I was like, well, why don't you combine both? So I went and spent some time with a friend who's a general practitioner and observed what he was doing, and hadn't really thought about general practice. But because it was a generalist profession, I was trained to be a renal physician, which is a very general. I really felt drawn to it, and I liked the idea of being a partner and kind of being able to run your own business and have that sort of way of thinking about managing resources and things. So yeah, combined both things and went back in and retrained as a GP. And so came out as a salary GP initially, 2006, and then in 2007 became a partner. And very quickly, it was in inner city Leicester, we were asked to take on looking after some practices that needed some caretaking. They'd really kind of got to the edge, the tipping point of really near collapse. And were at risk of kind of folding altogether. And being the newest partner in, I didn't really have a big gathering of patients that were going to miss me. So I volunteered to go off down the road and start in this little practice. And yeah, I learned just so much from that. So I ended up realizing that there were no processes. When you train to be a doctor, and when you train in general practice, you usually go to very well organized practices, so everything just works generally quite smoothly. But when I went there, there was just no processes. And about the same time, somebody gave me a book by John Seddon called Freedom from Command and Control, Making the Work Better. And it really changed my thinking, actually. It really opened up my eyes to just the ways that we could design a practice. So when you rebuild something, and then also how you work with teams. And so it set me off on a bit of a journey of how could we make this all work better? How could we think in a different way? And I guess it really kind of explored that bit of my brain that really likes to stretch thinking and think how to do things differently and not just accept the way things are done. So yeah, I guess from there, I kind of then spent 3 years working with 3 practice teams on how to do that and how we rebuilt these practices. And I really enjoyed that. And if I just don't spend too much time, but ask me more about that in a minute if you want to. I then ended up working for a national organisation called the Practice PLC, and we ran 45 surgeries across the country, and I got a chance to do more of this, kind of taking on practices that really needed to develop and embed different ways of working. I really enjoyed that. And then later ended up back in Leicestershire again, more based at home, and got into a practice again that was on the verge of collapse through, just the way things happen, isn't it? 2 partners retired, 2 partners became sick, and that was back in 2014. I joined for 6 months as a salaried GP and thought maybe I could get back into partnership again and join in and help rebuild this practice and do it as a team. So there was initially three of us, to rebuild, and we took the practice through a whole series of changes. And during that time, I ended up working with the local trust as well. So again, on that kind of improvement, how can patients have improved experiences of care, especially around where primary and secondary care interface. So yeah, I was at a trust for 3 years, and then went to the CCG and the CCG chair for a couple of years. And again, I can tell you a bit more of that if that's of interest as well. So I'll stop there.
So it sounds like improvement has been a sort of consistent feature in your career journey. Yeah. I'm interested to know whether you think improvement should be a part of all of, in terms of our healthcare sort of experience, whether that should be embedded within that, and should everybody working in primary care, for example, have some knowledge and expertise of improvement?
Yes, of course I'm going to say yes, because it's just absolutely, it's just in my blood. I think this whole thing about working, how we can improve. I think we, I think we know it. When we train to be a doctor or a clinician, I guess we end up becoming reconciled to the fact that we are always going to be learning for the whole of our career, because you realise you never get to the end of your knowledge. And in fact, it could be a continual source of frustration. It'd be lovely to know, wouldn't it, that you knew everything. And but you know, even yesterday in general practice surgery, I'm there with Google ready to hand to Google and check what are the latest guidelines on this, or what's this, or you know, we're constantly in a process of improving ourselves. So why would we think that where we work wouldn't need to go through a continual process of change? And I guess increasingly, and again, it's something I've learned over the years, is the co-production bit, is to make sure you're really working with people. So really important to me when I first started doing this work, almost without kind of knowing why I was doing it, but back in 2007-8, I was really keen that as we rebuilt these practices, we did it as a team. So we would sit down and set up like a team huddle and to discuss what's going on, and used, at the time I used a kind of instant reporting or / near miss reporting, so that we made it as easy as possible to report what hasn't gone right today and how can we fix that. And I guess in my most recent practice, where I was for 5.5 years, we had a sort of huddle on a Friday. We did it standing up in reception area, and we talk about what's gone well this week, what are we really proud of, and then what could have gone better this week, what could change or be improved. And it doesn't matter whether you'd been with us for 4 hours that day or you'd been with us for 25 years, everyone got a say in that huddle and could bring something. And if I give you an example of, like, one of the most things that makes me still really smile a lot is one of the receptionists saying, who'd been there a long time, oh, I'm really fed up because the prescriptions aren't getting filed in the right place. And that began a conversation around the room about, oh, well, is there more than one place? And then, oh, there's 5 places, why is that? And suddenly the group is process mapping by conversation what's happening with these prescriptions, and it culminated in the receptionist, you know, people don't even realize they're doing it, so you sort of empower them. And so she came back with a solution, which was, we've kind of worked out where everything is. We're going to do a little quiz now. We're going to test people, so we're going to make it fun for people to learn where prescriptions get filed, and it's not going to be a source of frustration anymore. And then you can check later, has that improved? Has that frustration reduced? And, you know, it's brilliant to hear it has. So empowering people, quality improvement is everybody's, you know, role and responsibility if you're in healthcare, and taking people along with you, and then including our patients as well as our teams.
I love that story about the prescriptions and how that just snowballs, isn't it? That you suddenly realise that there is so many layers to a story, and how people then all just jump on board. It's a really lovely, yeah, a lovely sort of picture. I guess that's the story around your work with caretaking practices. You sort of talked about how you enjoyed the challenge, but I'm kind of conscious of the fact that that must have been a really hard job as well. In that, you know, like you said, there were no systems, there was no processes. You were working from scratch. Yes, it's, you know, it's an enjoyable challenge, but there must have been times when you have felt really sort of like your resilience had been tested. So could you maybe talk to us a little bit about some of the particular challenges you faced and how you overcame them?
Yes, yeah, no, so absolutely. I'd never want to give this impression that it's all kind of Pollyanna, everything's just amazingly simple and straightforward. It's it always comes at a cost, and you've got to be aware of that. So there has to be some checks and balances for yourself and then for your team and what you can expect, because I think when you look around, so this practice that I went into, I mean, literally day one was marigolds on, black bin bags, and tidy up. And that was what I was doing. You know, it was, so the first thing is it's hard graft, and it's messy, and you have to be able to model to your team what it can look like to be on this journey together. That's the first thing. So I always try and make sure that nothing that I ask anyone else to do, I'm not prepared to do myself. So that's the first thing. I think secondly, it's building a team that you can then trust. And with caretaking, I think one of the really hard bits is when you go in is that you realise, you know, trust has to be earned, and it's really hard earned, but it's very easily lost when you make mistakes. And so having a real ability to be able to acknowledge when things have gone wrong and you could have done better, and actually apologising, and, you know, and all of that costs some things, doesn't it? Because it means you've got to be willing to recognise that things aren't going to go right. And so I try and build up a team, but there comes an opportunity, because I suppose I'm always on the lookout for who is the most engaged in this room, who really wants to do stuff, and how can you empower them to do it so that it isn't a one-woman show. This is not about Ursula coming in and caretaking, you know, this is about rebuilding a team. So the disaster for me would be if it is all about Ursula. And we have a joke in my last team. In fact, one of them did message me last week, and they said, we were having a moment about what would Ursula do? And I was like, oh, no, go back. You do remember how to do this. So we kind of go back. So you're trying to encourage and empower people so they don't become reliant on you. And also to really pull out of people what amazing skills they've got and hidden talents that they don't even know. So sometimes you might see them, you know, just even like that person suggesting about the prescriptions. Or when I was at the first practice we were caretaking, one of our doctors had noticed that between school and the Medina school starting, so the Arabic school starting after school, there was a real pressure on appointments for kids with fevers or kids that weren't very well. And this is pre-pandemic. I mean, we're talking 2007 here. So in a time when people with fever still went into school and things. So he wanted to really address that need that he saw for the population. So it was freeing up that clinician. What is it you want to do? So, and then have a go and test it out. And does it work? And how do you want to set it up? And supporting other people to do that, so that other people can bring their ideas and they can start to grow. And through that, you know, I saw salaried GPs who previously had been beavering away in rooms quietly suddenly find a space to actually develop into leads, become partners themselves, run an entire site, which they never thought they could do, or a receptionist who'd been there for a while, realizing they could become a reception manager or team leader. Or so I think you have to take the challenges and then see how other people can fill those gaps, and rely on that broader skill set of people, and realize that I haven't got all of it. So if you can empower them to go and fix some of the problems, I'm not getting stressed as well.
Yeah, absolutely. Is that you like you said, no single person can carry the can, and it is about empowering others as much as it is about empowering yourself as well. You touched on some of the other roles you did, so I want to kind of move on to talk about those as well. I'm aware that you did a sort of associate medical director post within a trust, and then also took up the position of chair of CCG as well. So I'm keen to hear a little bit more about your experience of those roles.
Yeah, sure. So the associate medical director post is funny how I ended up there, because my partners decided that I had to go to the system meeting. So it was like a system meeting on elective referrals or something like that. And I was sitting in this meeting representing our practice, just thinking, gosh, this meeting's full of a load of jargon that I don't understand, and what is going on here, and what are they asking? And I just don't really so frustrating. And I was sort of sat there a bit sort of not really focusing. And then the person that was leading the discussion on the table zoned in on me and sort of said, "Oh, you haven't said anything yet. What do you want to say?" And I said, "Oh, well, I've been thinking," because I've been off drifting about how I would do it differently. I was thinking, well, I wouldn't do it in, what you're describing. I'd probably approach it in a slightly different way, and I'd be thinking about this, this, and this. And they took it really well, this feedback I was giving, and they said, "You should come in and talk to me. I'd really like to follow that up." So I went in, and actually that person was the head of strategy at University Hospitals of Leicester. And she said, "Would you come down to this unit, the cardiorespiratory unit, and have a look?" And the challenge she asked myself and another GP who was also a public health specialist to do was go and have a look at this and to see if we could move some of the capacity to a community hospital down the road. It was something like that. She set us a bit of a challenge. And actually what happened was we went in, and as we started to observe what was happening in this unit and sort of pick up on what was going on, we realised this unit was totally compressed. It was so many reasons why it was compressed, and actually lifting and shifting patients down to a community hospital was possibly a solution, but actually there were lots and lots of other things that we wanted to unpick and understand. And so that led to a project where we got some Vanguard pilot funding for, and we worked with the team on that unit. And we realised that about a third of the patients that attended the unit were waiting 6 hours or more when their test results were normal, and they could have gone home a lot earlier. And the compression, or the pinch point, was waiting for the consultant to sign off and approve their discharge. And again, through a series of kind of working with the teams and iterations, we kind of mapped the whole thing and looked at it, and we put in a suggestion, which was a trial of bringing a GP in to work alongside the specialist nurses that were already based in the unit to provide that top cover, and to see if by doing that, and by a series of other changes that we made, could we decompress the unit by speeding up turnaround for people with normal results that could go home. And it worked. We did a series of PDSA cycles, so plan, do, study, act cycles, and we iterated it. But essentially we brought in the GP clinical system. They wrote directly into GP notes. We managed to get hold of the ability to have green prescriptions, so you could generate a prescription that a patient could leave the hospital with and go to any pharmacy of their choice. And we unblocked all these blocks that existed, even to the point where I had pathology manager down to the unit to look at how could we speed up turnaround time of blood results for these particular patients. And we found that a brick wall was obscuring the view of the pathology lab to see urgent samples arriving, and that other wards kept pinching the chute bottles for the pathology bloods from this unit, because they knew their bloods got prioritised. So we sort of unpicked a whole load of kind of challenges and issues, and then set about fixing them by including all the people that needed to be in the room. So that pilot basically showed that for an 8-hour GP-led with a specialist nurse from that unit clinic, we could discharge safely the patients that we saw with a 99% patient satisfaction rate and a median time on the unit of 2 hours instead of 8 hours. So yeah, it was a really good pilot. And in fact, although we had a bit of resistance from some teams when we started, I remember getting stopped in one of the corridors of UHL by somebody who'd been quite vocal about it not going on and some concerns about clinical governance, saying to me, "You're not going to take that unit away, are you, Ursula?" And it wasn't even in my power to say yes or no to it. It was a pilot that we were doing. So we knew we'd won them over with something. So that began then 3 years of working with the hospital teams. I did some work in the emergency department, again, mapping patient footfall to how we provided teams. So what you commonly find is that rotas don't match the patient footfall. And so people can be sitting around for a couple of hours really waiting for things to get going because they all start at 9 o'clock in the morning, and yet GP surgeries don't start referring in until about after 9:30. By the time the patient gets there, it's 11. And so moving when people start their work to a different time in the day means you're then hitting peak capacity at the same time, so matching capacity and demand. It's all that kind of work I was doing, really, among some other interesting things.
Yeah, I like that story, particularly because I think it highlights within you a particular quality, in that you were told to do something like around moving patients down to the local community hospital, but actually you had the courage to challenge that and to come up with some new and creative ideas. And again, I think that's such an important quality for people who are invested in improvement. Can I ask now how, because you've done the associate medical director role, and I want to hear about the CCG chair role as well. Is that something that you had aspired to, or did you find yourself in that position?
Yeah, so famously about a week before, I had said to a colleague who, because I just noticed actually our CCG was increasingly disengaging from collaboration in our system. So because I had this unique role in the trust, I got to attend some of the system meetings, which was a really new position to be in as a GP working with the trust, to be sitting on a sort of, if you like, a different side of the table. And I'd spent time building up relationships across local authority, the other CCGs, and our local community trust. And so I was a little bit discouraged and disheartened when my own CCG, where my practice was based, was not really, well, they had quite a lot of objections and concerns to collaboration. And it kind of culminated in quite a big meeting where it was discussed. And again, I just found it very, very disheartening to hear people talking about people in organisations. It wasn't about people, but talking about organisations. So in this organisation, it's like this, or in that organisation, it's like that. And I did speak up at the meeting and just say, look, I just don't know who you're talking about, because I find there are lots of people in that organisation that I can work with. So what is the actual barrier to working together? And I couldn't quite unpick what it was. So this opportunity then for applying for chair of the CCG came up literally a few weeks later after this meeting that I'd been very frustrated and disheartened about. And I really, truly believe that actually working as a system, working together across lots of organisations and people, it is the way to work together and fix things. It really, really is. You need more people in the room than less a lot of the time to share thinking, especially on big challenges. Especially that in the NHS, we have such big challenges, don't we, on limited resource, limited workforce. We've got big challenges, but actually there are lots of solutions out there and other people thinking in different scenarios about similar things that we can learn from. So I stood for chair, which meant you had to be elected. So I set out and offered all the practices in our patch. There were 31, I think, at the time. a chance to come and visit and just listen to them about what they thought and just to understand really. So I did that and I got elected, which was really quite a surprise because I'd made it clear from the outset I was pro-collaboration, and then set about, that was in 2018, really working within the CCG and across the system to really talk about why collaboration was important in my view and in other people's views, and to try and understand why people didn't think it was a good idea and how could we work together to sort of unpick that and understand it and get it into language where we could understand, and really then from understanding move forward to then hopefully finding solutions to move forward together. And it's a really good thing because actually by the time I left to move to the east of England, we had successfully agreed to appoint a single accountable officer across 3 CCGs. We were working much more closely, and by the time the pandemic hit, all that work for those 2 years really brought us, you know, we were ready to work together in that moment of crisis actually. So I was still at the CCG for 6 months during the pandemic when it first started, and it was just so good to be together as part of a bigger group working together to address what is the biggest challenge we've all faced in a long time.
I've got a sort of policy question for you now. So I can see that you're very pro collaboration and that sort of held you in good stead in your CCG role. Now that sort of integrated care systems are coming into being, what do you think the future is? Do you think that they are sort of credible entities, and what is the role of primary care, do you think, within the integrated care systems?
Yeah, no, that's a brilliant question, Ramya. From the time in the CCG, the thing I really enjoyed learning about being in a clinical commissioning group was working with the local authority, and I can't begin to tell you just how much I learned. I had regular kind of catch-ups with the Chief Executive of Leicestershire County Council and other members of Leicester City Council, and it just brings a totally fresh perspective and also the opportunity to really join up. There was a blog by Roy Lilly years and years ago actually about how health and social care were siblings separated at birth, and how when the NHS was formed in 1948, health and social care got sort of divided, but actually they are siblings, so they need to work together. And so for me, the integrated care system, it really will work if we make sure we get all the different partners in the room. And within that, I'd also include voluntary sector and third sector, because in my time in the CCG, I also realised that we hadn't been working as closely with them as we could have, and actually really pulled them into those discussions and all their knowledge and their understanding of the strengths that community have and some of the gaps where we're not providing services. So I really think that is fundamental. And then primary care, I absolutely believe that primary care's general practice is fundamental. And in fact, one of the chats I used to have with the local authority chief exec, he used to say to me, in the local authority, we have a political mandate to serve our citizens. In the NHS, it's you're not elected, although obviously I have been by my member practices. You don't have that same sort of mandate, and you can see how that mandate really drives their passion and their enthusiasm and everything about how to create services for their citizens. And it got me thinking, and if you think about general practice, we're probably the most closest to a mandate, in that patients often, not always, have a choice which practice to register with, and they can choose where to register with generally. And so I think by their choosing and registering with that practice, you do have a mandate as a practice to really understand what that community that's registered with you want, needs, and could work together with you to help provide better. And so that's why I think primary care is so fundamental, because of that general practice patient list in the role of an integrated care system. But more than that, primary care is really, really focused on prevention and the management of complexity and the management of complex care and the sort of gatekeeping of the resources of the NHS. So in any integrated care system, how would you not have primary care clinicians around the table when really that has to be your key driving areas? How can you keep your population healthier? How can you manage the complexity? And how can you really manage resource really well?
Yeah, I completely agree with you. I think, yeah, we couldn't do any of this without primary care being sort of front and centre. But I think we've also got to acknowledge that, particularly in general practice, it feels like we're in a really precarious place at the moment. What do you think the future is for general practice? Do you think that the sort of current model is viable and sustainable, or do you think that general practice will look quite different in years to come?
I think that is in the hands of the partners that hold, or the people that hold the contract. I think it's totally within our ability to really, as contract holders, we've got huge room to do quite a lot. A lot exists within our control. There is a lot of things that come our way as partners or as holders of contracts that sometimes we can't influence, but there's also a lot within our influence. And that is why I've always enjoyed being a partner. I've worked as a salaried GP as well, but it's that investment in, as I said, that community that you're serving, the holding of resource and the ability to innovate and transform on a very, like, your footprint, but to also then work collaboratively with other practices. So primary care networks is an example of that, but even before primary care networks, practices were collaborating. There's absolutely no doubt about that. And before primary care networks, practices were innovating with the resources that they had. So I think it is still within our gift. I think the challenge we have as leaders and as contract holders is the space to think and the ability to be able to carve that time and opportunity out with all the competing demands and pressures. I don't see the model of general practice changing hugely in the sense of the contract. I think it's the way that we provide services to our patients that may need some more transformation and some thinking through, but that has to be very much rooted in and connected to your community, your population, and particular features and distinctions of your population, and how you create those services to match that need.
As you were talking, Ursula, I was reminded of something that Virginia Patania said on a previous call we've had with the Q community. She sort of said that the NHS will never have enough money and we will never have enough GPs. And it's making me think, is it really the case that actually we can solve some of these sort of burning issues within primary care through better use of resources and through better use of improvement sort of methods and so on? Or is it a mixed story? Is it a case that actually, yes, we need more investment, but we also need to maybe be rethinking how we deliver care?
Yeah, I mean, so I'm going to say it's a blend, isn't it? Because we have to accept we have a finite resource. We have to accept that. So it doesn't mean we can't lobby for more or ask for more or come up with ways to bring more resource in or look for different ways to think about it. But we are always going to face those challenges. So I completely agree with that. But what I would probably say is, if everyone's here thinking, yesterday when you were at work, did you see a way of something being done differently? Did you see duplication or repetition or wasteful processes? I mean processes, waste in your process design, then there's surely an opportunity there right now. So I couldn't hand on heart say we have to have, until these things are addressed, we can't do anything. I think we can. I just don't want anyone to think that I'm not acknowledging how challenging it can be. And I also have experienced as a partner where I've sought to address capacity demand, look at new ways of doing things, that it does require investment, which then does hit partner bottom line. And then there is a tension between how much can partners earn and how much can be reinvested. And there is a genuine tension there, isn't there? That how do we do that? So I've also lived through that sort of experience as well.
Great, thank you. I know that there's quite a few people waiting to ask questions. I'm going to ask one last one and then open up to the floor. I know that many people in the primary care community really respect and admire you, Ursula. And so I want to find out from you what your advice is to people starting out at the beginning of their career or even mid-career who are looking for the sort of next steps. What would you advise them in terms of shaping what they do and being able to make an impact on healthcare?
That's really lovely feedback. Thank you, Ramya. I never set out to be here, so I can't promise. I think what you have to do is find what you enjoy and then do lots of it. And I've always found things that I enjoy, and I haven't gone after things because I thought it was something I should do. Yes. And I mean, as you can see, I haven't followed a very conventional career path at all. And so sometimes in the middle of it, as I'm sort of filling out my CV, sometimes I think, what on earth is going on here? But I've just really enjoyed all the things I've done. I've really benefited. And again, this might be seen as a bit controversial by people, but I really benefited from my time in the practice PLC and in health, who I haven't mentioned actually, but I worked for, because I really benefited from seeing how corporates run things, how incredibly focused on their patients they are, and how they really genuinely want to improve things. And I learned so much from their freshness of thinking and their ability to innovate quickly and think through and really pull different people in. So I'd encourage you to look inside and outside, and to be always, I'm always reading and looking around for things that might stimulate my thinking. So especially outside of the NHS, so I try and read things that are going to stimulate what would this look like if we did this in health, or and ask those questions. Can you get into a position where you are thinking, why is it done like this? Why do we have to accept this as this? And just be brave. I think at times, I have to say, it's been my husband mostly who's been like, you can go and do that job, you should apply. And I've been like, no, I don't think I could. And he's sort of been pushing me from behind, going, go for it, be brave. So I think I've had to overcome. I know you might not think that looking at me sometimes, but inside I am a bit of an introvert. I've had to learn to be more extroverted, and I've had to have a bit of a shove to go and do things. So find somebody that's going to be your cheerleader and kind of cheer you on and push you and encourage you to try some different things. And you know what? So what if it doesn't work out? I think that's what I've always thought. I'll go and try it, and I'll see if I can do it. I don't know if I can do it, but I'll have a go and I'll learn a lot on the way. And as long as I'm doing that, I'm happy.
Great, I think that was wonderful advice. Joriam, I'm going to open up to the floor now. So I know that a few people have posted questions. Are you able to bring them in?
Sure. The easiest way to do this is just if you folks use the raise hand function, which is in this button called reactions. I know, sorry if I mispronounced that, not a native speaker, but Sheenaz and Caroline already posted questions over there. I would invite them to bring them forth first, if that's all right. Sorry, John, I saw you already raised your hand. And then, yeah, we just follow the order of people raising their hands.
Hi, Shanaz. I just love hearing your story, Ursula. And yesterday I celebrated 41 years in the NHS, and the last, and the last 14 have been in general practice. I was leaving the NHS, like I came here for 18 months, and I've been here 14 years. And actually, it's quality improvement that's got me through the most challenging times. And I suppose the issue for me is because I can see the value of quality improvement to help me in I have an MBA. The MBA didn't help me to do my job, but the things that you articulate, the things that you feel passionate about, are the things that I find having a quality improvement background helped me to deal with in the practice. Gives me structure, gives me strength actually, because I can see outcomes. And we see the pressure on clinicians articulated, but we don't hear about the pressure on non-clinicians. And I'm just wondering, what can we do to get practice managers involved? What can we do to help practice managers to get into this space? Because I'm 41 years on, I'm not looking to leave, because I feel so inspired with the things that we need to do.
Yeah, no, Shanaz, it's lovely to see you, and I know you do a fantastic job, and you're part of Time for Care as well, and you do the quality improvement work, so that's brilliant. And I think you're absolutely right, and actually I should have said, another really sentinel part of my career was actually spending 2 separate 6-month blocks as a practice manager when we didn't have one, as well as a partner, and it was really challenging. I really agree with you about how can we raise the profile of what practice managers do, and primary care network managers as well, and the value of managers. And for me, it just goes almost without saying, I totally appreciate management, and I appreciate operational management and all sorts of management. And I'm working with different practice manager groups in this role that I have nationally to really hear that and try and understand that. And we're working now with the primary care policy team on how we can bring in some increasing opportunities to really value and recognise practice managers. I think you're right. It's so I guess one of the things that I've been contributing to internally in the national team is, when we talk about retention, often we focus on, as you say, retaining clinicians in particular groups. But retention is a team sport. If you don't have a fantastic practice manager, there won't generally be a brilliant recruitment process, a really good induction process, a really good person to make sure that that person's settling in really well, and then somebody that's going to kind of catch up with them and sort of see how they are, because partners generally are busy doing the clinical work, or certainly in the practice that I've been working in, we've really needed our managers. So yeah, I think it's ongoing dialogue and discussion on how we can do that better, and I hope that we'll start to show some action from that in this next 12 months, Shanaz, and you can come back and chase me down if we haven't done that.
Thank you. I think that's supposed to be a clap.
I think is Caroline there? She had a question. Right.
Hi, Ursula and everybody. Thanks so much for a really inspiring time. I really loved your advice, and I think at the moment it's really important to have the encouragement to keep going, because I think when we are innovators and we need to, it's our passion to keep going forward. Yeah. At the moment, it's quite easy to feel a bit tired and a bit kind of, so that was really positive. That's not my question. I've got 2 questions for you. I'm really interested in your views about the role of clinical psychology in private practice and how it can best be used. And I'm mindful there's Centre for Mental Health has just issued a very interesting paper on that. And then the other thing I'm interested in is if you've got any tips about the interface between primary and secondary care, because that's so crucial, but often is something that's can easily become a chasm. Thank you.
Yes. Oh no, thank you, Caroline. Nice to meet you. And yes, on the first one, clinical psychologists, It's an interesting one because we've definitely been working with the mental health team, and we've got the mental health practitioner role in the additional role scheme. But as you were talking, I saw the question in the chat, I was thinking, yeah, I'm not sure whether we've got clinical psychologists. I can't answer that question exactly, but I think you're right. It would be good to be thinking about that and how that works. At the moment, the mental health practitioner role is about bridging people that have previously been felt to be not meeting the criteria to refer into acute trusts and are being held currently in primary care by general practice, and whether the mental health practitioner can bridge that gap. So it'd be interesting to know, and maybe we could follow up afterwards about whether you felt clinical psychologists could, just to think that through. And then secondly, on the primary care interface, I mean, the very first thing that's fundamental is get primary and secondary care talking together. Secondly, I think make sure that primary care feel like valued customers of the trusts. So, and maybe people might not like the word customer, but I just think I have a general principle that we're all customers of each other. So we're all here to sort of serve each other in different ways. And sometimes I'm here to serve, and sometimes I'm also a customer receiving something. And so I just think we need to improve that, because primary care have a lot of legitimate concerns. And then equally, it's a two-way conversation, isn't it? So there needs to be this continual learning cycle, then where feedback from our colleagues in secondary care come back into primary care so that we can understand. And if you take, for example, advice and guidance, I spoke to a renal consultant, and he was saying to me, oh, advice and guidance, I just end up with, I've got to get the same 5 requests all the time. So I just said to him, okay, so have you thought about putting together a presentation or coming out and do some teaching to primary care? If it's the same 5 things, maybe there's some things we could do differently or know about, if, what could it look like? And so I think if you can create space for dialogue, and you can create a two-way feedback cycle and opportunities to learn, that will go hugely into, and create a customer service approach where we value that, then I think that will come better.
Great, thanks, Ursula. John, do you want to come in?
Thanks, thanks Ramya, and thanks everyone. So I'm John, I'm a GP in North Central London. Ramya, as ever, you've expertly hosted a conversation around what I think are sort of 3 roles, Ursula. So there's you as a person, and thank you for being open and honest with some of the experiences that you've had. Then there's us, or us in our role, so what job we do and how we navigate what is often a very organic career and not planning as so much. And then there's the third aspect, which is how do we represent the current organisation that we work for, and particularly for a number of us who I know on this call, where we work for lots of different organisations, sometimes that can feel challenging. I've got questions about all 3. I'm going to ask 2 questions because there's the time basis. But number 1, your comment about working with the local authority as that sibling separated at birth. And we know that family relationships are complex and difficult. I see the voluntary sector then as the cousins, and bringing the size of that family unit together is important. I'm wondering, do you see a difference where the footprint of an integrated care system is different from the footprint of an integrated care partnership, so a borough-based arrangement? Because that does seem to be fundamentally different from my experience in North Central London to, I know, some other areas of the country. And the second point that I've jotted down on my scrap of paper here is your comment around the future of general practice really being in the hands of the contract holder. And specifically, you mentioned partners a number of times. I, along with at least 50% of the GP workforce, I'm not a partner. We know about the fragility of the partnership model. You spoke about your time with the Practice PLC, supporting practices who have fallen over or in trouble. And I guess there is a bit of anxiety if the power to decide the future is held by the contract holders, where those contract holders are becoming conglomerates or outside organizations. It does feel slightly risky. And I just wanted your reflections, I guess, on those 2 points.
Yeah, no, thank you. Nice to meet you, John. I think you're right on the ICS, absolutely. You're talking about a place, the place-based arrangement. So the borough, it might be in your patch. So for 42 ICSs, they're very different geographically and have very different footprints. And I think you're absolutely right. And it was an omission in my description of why I thought they'd be good, is place for me is a really key part where that partnership with your local authority will work through. And that could be at borough level, it could be at, so for example, in Leicestershire, it would be at Leicestershire County Council level. And then we had Rutland County Council as well. So we had 2 places within that system, and then a third with Leicester City Council. So we had 3 places. And yes, you're right, being able to, I think there's a lot of attention on ICS and at the system level, but you're right, I think everything will happen on the neighbourhood or community footprint, and then on a place level, very closely aligned to local authority and voluntary sector organisations who will know where the strengths in the community are and where the gaps are as well. So completely agree on that one. And then the second one, yeah, I think it's the future of general practice. So I was describing, I guess, the current situation we have. And you're right, it doesn't represent those that are salaried GPs or work as maybe locum. How do we include everybody to input on what the strategy is? So I guess that is the conversation back to the contract holders, and back to what I was saying is, how do we want future general practice to look? Do we ever have conversations like that? Where does that happen? I don't know. And actually, how could that happen better? And what would you like it to look like? And on the issue of companies coming in, I mean, I know that is controversial. And when I went to work for the Practice PLC, it was viewed by some of my colleagues as a bit of a controversial step to take. I like I said, I learned a lot from it. I think it's, again, recognizing how can you work in partnership with people, and try not to demonize an organization without first knowing the people inside it and understand what their vision is and their values and their purpose. And if you're aligned to their vision and values and purpose, then why couldn't you work together if they have commonalities? So I think it's about us working together as a profession, and more than that, thinking about the increasing roles that are coming in. How are we going to make sure that we get everybody's view in to what is the future? What does it look like? What is our vision? What are the values that we really appreciate about general practice? Because I can think of lots that I really appreciate. And then how does that look for the future so that we deliver the best care for our patients?
Thank you, Ursula. As anticipated, the hour has completely just flown by.
Wow.
So I just want to sort of close now. And firstly, I want to say thank you to you, Ursula. We had a conversation a couple of months ago, which I found really supportive. And you just told me part of your career story, and I found it really helpful. And it's been a really great opportunity to then share that in this wider group. I'm sure you've kind of touched many people here today and inspired them. And I love that piece of advice about just going out and putting yourself forward. There's nothing to lose. And I'm very much trying to live by that myself. So yeah, huge thank you. And thank you for your time today, everybody who has joined us. I hope you enjoyed the session.
Yeah, thank you.